next presentation is actually two for the price of one. Ashley Mangin, occupational therapist, and Jena Becker, speech therapist, are from Building Abilities. They work in a private practice in the Chicagoland area, and they specialize in collaborating and co-treating children with sensory motor needs of all ages. Personally, I'm a huge fan of therapy collaboration. I know some of my most successful speech therapy sessions have come from techniques that I've learned from OTs over the years. And so Ashley and Jena will be teaching us about just that today, treating the whole child from the OT and SLP perspective. Take it away, ladies.
Thank you. Hello. Let's see. Share. Okay, so today we are going to talk about how we collaborate as an OT and an SLP to treat the whole child by integrating sensory, motor, and communication needs simultaneously. So I'm Jena, I'm the speech therapist, and this is Ashley. She's the occupational therapist, and we work together in a multidisciplinary clinic in the south side of Chicago, and we do a lot of collaboration. So this is what we'll chat about. Multisensory experiences help deepen learning and memory, especially when paired with movement. This quote from Gil Connell comprehensively describes how we'll go about structuring treatment sessions for all of our children, whether it's a co-treat session or just an individual speech or OT session. So how to incorporate the movement and sensory integration strategies into your speech and language session in order to deepen and maximize the learning and engagement for each child is what we'll speak upon today.
So what is sensory integration? We can talk about this for a long time and kind of dive into each sensory system. But today we're just going to kind of do a general overview of all of the systems. So sensory integration is the processing, integration, and organization of sensory information from the body and the environment. We have all of our five senses, as well as the vestibular system, the proprioceptive system, and the interoception, which are the three systems that a lot of people are unaware of. But they're a big part of how we interpret the world around us, our bodies, and how we move through space. So first we're going to go over the auditory system, which is the sense is responsible for hearing. The visual sense helps the child see and detect things within their environment. The tactile sense helps a child detect light touch, deep pressure, texture, temperature, vibration, and pain. The gustatory sense helps a child detect and perceive taste. The olfactory sense helps us differentiate between different odors and determine if they are foul, pleasurable, or dangerous. Proprioception is located in our muscles, joints, and connected tissues. It provides us with a sense of body awareness and detects and controls force and pressure. This input can be obtained by lifting, pushing, and pulling heavy objects, including one's own weight. The vestibular sense detects and interprets movement through the sensory receptors in the inner ear. It tells us the position of our head and body in space and its relation to the pull of gravity. Interoception refers to the sensations received from your internal organs, helping you detect and feel what is going on inside your body, including hunger, thirst, temperature, and pain. So this is a quote by Dr. Gene Ayers. When sensations flow in a well-organized or integrated manner, the brain can use those sensations to form perceptions, behavior, and learning. When this process is disorganized, it will affect many things in life. So as an OT, is it our job to assess and determine what sensations are being affected and how we can create a sensory-rich environment or activities tailored to that specific child in order to optimize their learning experience.
So what does this mean for the SLP? Well, it has become more commonly accepted by treating therapists because we see the benefit in our day-to-day sessions. Sensory integration has historically had much controversy surrounding it due to the limited amount of empirical evidence to support its direct application to our clinical population. But what research has been conducted does show a positive link between speech and language deficits and frequent co-occurrence of sensory integration difficulties. Studies have also supported that sensory integration therapy can support and help foster a number of speech and language gains due to the need to integrate information for learning from multiple sensory sources. We don't have enough time today to go into all of the research, but we have extensive references at the end of our slides, and we'll put that on our Instagram as well, for you to reference if you're interested in that research piece. So as an SLP, how do we integrate these SI strategies? We're not saying that you as a speech path need to be an expert in SI or motor needs. In fact, we recognize we want you to recognize that we are not the experts. But as soon as your child walks in the room, your first question to yourself should be, how is their arousal state? What is the attention looking like? What is their nonverbal communication telling you? And then, if able, ask them, are they ready? What does their body need? It's imperative to look for the signs or those red flags that they may need some sensory motor input either before or during your session. Ideally, you'd spend some time co-treating with your OT. As each of you are treating, you should be explaining to each other what you're seeing, what should be done about it, and how to know if your treatment is actually working. We always want to make sure that the SLP is aware of what the OT sees and is working on. And likewise, you want your OT to be knowledgeable about how to support your child's communication when you're not there. Then fade your co-treat to an overlap or back-to-back sessions. And when the child's ready, especially in the school setting, you can move to those individual sessions, but consistently be collaborating and discussing that child back and forth. So in order to help create a better understanding in such a short amount of time today, we're going to present 3 different case studies of kids who came originally to me with speech and language concerns, and it was apparent right away that I needed to get OT on board and part of the team. So our first little friend is Caden. He was 3.5 with a diagnosis of developmental delay when he came in. He presented with pretty significant language processing difficulties and very limited expressive communication. In my initial sessions, he explored toys by mouthing them, and if he wasn't putting the objects in his mouth, he was constantly chewing on his clothes. He was extremely distracted in a busier environment, such as the gym or the waiting room, and he was seen and reported to seek out climbing in very unsafe environments. He was unsafe on the playground, he was climbing onto tables and counters at home, and also he'd flee from me and from mom, oftentimes running out of the waiting room into the parking lot. So after that initial eval, in those first few sessions, we got OT to join in and be a part of the team, and we progressed from there.
So in this case, the child was seeking climbing, crashing, and taking excessive risks because he was looking for a way to help regulate his nervous system. He was easily overstimulated by auditory and visual stimulus, which explained why the waiting room was such a challenging time for him. So in this case, we chose to start with a lycra swing with linear vestibular input, which is kind of just going back and forth within the swing. In order to take away the visual and auditory input, we used the lycra swing. So within, this gave him the opportunity to shift his attention to the speech therapist to target language skills in a structured task while in an organized state. He was able to give himself prop input while swinging by pushing his feet and body into extension and flexion. And eventually, when he was at his optimal state of arousal, we were able to work up to a simple swing and crash sequence, given a very structured environment and visual schedule. We watched his nonverbal communication and went back to a vestibular-rich sequence when we felt it was necessary or when he was becoming overstimulated within the room. Since he was seeking orally, we encouraged the use of a chewy tube throughout the session, as well as blowing bubbles throughout our play activities. If you have a child that is similar to this, but don't have access to suspension and swings, you can modify your environment by providing dim lights, a quiet and smaller space with minimal distractions, or minimal equipment within the room. Provide structured visual schedules, use less auditory cues, and replace linear swinging if you don't have a swing with maybe rocking back and forth on a ball. This next slide just kind of goes over a ton of different ideas for giving your child a vestibular input, but a lot of things that you can do in the home setting. And we have this up on our Facebook and Instagram as well if you don't have time to look through it all today.
Okay, our next friend was Elsie. She was an almost 4-year-old girl that came to me with a suspected diagnosis of apraxia of speech. And it's not uncommon that I see sensory difficulties kind of intertwined with those motor planning deficits when I first start treating a child with apraxia of speech, especially if they've never received therapies before. So in this situation, I might say to my OT, I have a new child with apraxia of speech that has difficulty sustaining visual attention to my face or mouth, which we know is imperative to treating kids with apraxia of speech. We need them to watch our mouths, watch what we're doing. Tactile kinesthetic cues such as prompt or just even touch cues were very beneficial to her, but after a short amount of time, she was visibly uncomfortable and brushing those off. and she has a very short attention span to the therapy tasks. She's unable to sit and attend to one activity for more than a minute or two before needing to move around the room. So I would come to Ashley and ask her what she would suggest.
So in this case, it was apparent that the child was very tactily defensive. Some of the red flags that stood out to me were a big personal space, poor transitions, especially unexpected transitions. She had a need for control within the environment and the people around her. My initial suggestions were to build rapport and get down on her level. I would build trust and comfort with the child first, because if you invade her personal space before she is ready, you will not see the progress that you are looking for due to her guard still being up. I would encourage a sensory-rich sequence that is organizing to the child, since she will be receiving facial touch cues from the therapist, which is a tactile experience by itself. In this case, proprioceptive input was very organizing for her and helped calm her nervous system in preparation for the speech task. So this little girl benefited from a proprioceptive rich sequence, such as climbing over, crashing into cushions, crawling through a tunnel, and completing a speech task at the end of it. This sequence was structured and predictable, which allowed her to still feel comfortable and in control of the task. This next slide is just a bunch of different ideas for proprioceptive input that you can do in the home setting, as well as a therapy, a clinic setting. And this is on our Instagram and Facebook as well if you want to refer back to it.
Our last little friend that we will talk about is Claire. Claire was a 6-year-old that came in with low tone, a weak core, articulation deficits that were impacted by co-occurring orofacial malfunctional disorders. She was referred to and seen right away by an ENT. She had PE tubes put in place and adenoids removed, but her tonsils were okay. She still presented with a tongue thrust while swallowing, an anterior lingual protrusion on those alveolar phonemes. She still had a habitual low resting tongue posture as well. We're making limited progress outside of the highly structured activities within our sessions. She was already in OT, so we had been collaborating, but Ashley had some more suggestions of things to do within the speech sessions to optimize her learning and improve that progress.
So a child like this will be working with their OT sessions on strengthening their core and postural stability. You can pair postural activating activities to support your child's speech and oral motor skills. I would facilitate quick movement activities such as tug of war, playing catch on high knees, wrestling, pillow fights, dodgeball, safe boxing. Breath support is a key element to dynamic postural stability, so which together are going to affect proper lingual resting posture. Many of our clients hold their breath or stabilize their tongue in an atypical state, as well as have restricted movement of the diaphragm. So you want to focus on long exhale breaths with core and postural activating activities in order to break the pattern of breath holding. When thinking of the collaborative approach, we think about facilitating activities that challenge postural control and trunk strength with an additional focus on appropriate breathing patterns, oral resting postures, and/or articulation movements. Some activities that are helpful to integrate these skills include yoga or adding controlled rotation to a play task as pictured here.
If your child presents with orofacial malfunctional disorders and overall core weakness together, it's imperative to collaborate with your OT or even a PT regarding best positioning options when working within your session on speech tasks while they're in the classroom or when they're eating.
So if your child has poor postural control, you may see this with them slouching, leaning on chest or arms for support, frequently fidgeting or falling out of their seat. I think a lot of people misinterpret this as sometimes like those sensory seekers, but I think it's really important to think about if the child has poor postural control, instead of giving them a wobble cushion or giving them a rocking chair, if you are kind of thinking that they're seeking additional input, look at their postural control and really interpret if somebody does have poor postural control, that they should have proper seating and they should feel supported. So their feet should be on the ground. They should be on a firm surface underneath them, and their back should be supported, and their arms should have some side rests.
So overall, speech needs OT, and OT needs speech, and together, and of course with the input from the child's caregivers, we can become the experts on our children, understanding and treating the whole child. It's important to learn what specific sensory motor needs your individual child has in order to support those and optimize the learning and progress within your speech sessions. Kids are not meant to sit still all day, so we want to enhance their learning by providing movement and sensory motor experiences within your speech sessions and their therapy activities.
I would encourage all of you to collaborate with one another in order to treat the whole child and not just one component of your child. Please reach out if you guys have any questions or need to problem solve anything. We're happy to help.
Thanks, guys.
Thank you.
All right. Thank you so much for sharing. And your Instagram is at Building Abilities, right?
Yes.
So if you want any of that information from them, they post lots of awesome information on their Instagram account.